Lucian Isak was 55 years old, a lifelong non-smoker and in peak physical condition. In February 2025, he crossed the finish line of a marathon. Just 1 month later, he noticed swollen lymph nodes on the left side of his neck. An ultrasound-guided biopsy confirmed the unthinkable: stage 4 metastatic lung cancer. For a fiercely active athlete, the diagnosis presented a sudden, terrifying physical cliff. His lungs, the very engines of his endurance, were compromised by a sprawling network of tumors. A tissue panel revealed a crucial detail: a genetic typo known as the EGFR L858R mutation. Because the cancer relied on this flaw, doctors bypassed traditional chemotherapy. They prescribed a daily pill, osimertinib, to seek out the mutation and shut off the tumor's engine. The biological response was rapid. By July, CT scans showed the primary mass in his left lung shrinking and the dense cluster of cancerous lymph nodes in his chest retreating. Typically, advanced metastatic lung cancer aggressively degrades a patient's stamina. Yet, by the fall of 2025, Luke was lacing up his running shoes and completing marathons once more. By mapping the exact genetic architecture of a tumor, modern oncology can trap certain advanced cancers in a holding pattern. Patients can maintain active, rigorous lives, provided the tumor's biology doesn't learn how to adapt. In October, a routine scan caught a mechanical glitch in Luke's circulatory system. He had developed a pulmonary embolus, a blood clot in his right lung, requiring immediate daily blood thinners to prevent a catastrophic blockage. The blood thinners were a manageable detour, and his medical team decided to press their advantage. They scheduled a high-dose, localized radiation course to aggressively burn away the remaining primary mass in his left lung. But during radiation prep, imaging revealed a structural failure. Cancer had seeded the lining of his left lung, creating a malignant pleural effusion. The pooling fluid physically compressed his lung and displaced his heart entirely off-center, making it impossible to aim radiation beams accurately. The pressure inside his chest grew severe. Luke was admitted to the hospital, where doctors manually drained 1.75 liters of fluid directly from his pleural space. Treating a complex disease requires maintaining the infrastructure that surrounds it. Eradicating tumor cells yields no clinical benefit if the surrounding respiratory plumbing collapses under the physical pressure of the disease. The relief from the drainage was brief. The fluid rapidly reaccumulated, and the thick, cancerous scarring on the lung lining prevented the tissue from re-expanding, leaving Luke with a mechanical deficit known as trapped lung. Systemic failures began to cascade. A new blood clot formed deep in his left thigh. His respiratory capacity plummeted to the point where simply holding a conversation or walking up a slight incline left him gasping for air. As the structural damage progressed, he developed sharp, shooting nerve pain that radiated deep into his left upper back and along his spine, severely disrupting his sleep. The clinical data pointed to a single, stark conclusion: the daily pill was no longer holding the line. The cancer had mutated again, finding a biological workaround to bypass the medication. Targeted therapies rely on a precise molecular fit. When the tumor mutates and alters that structural signature, the medication can no longer bind to its target. The resulting freefall is immediate, stripping a patient of their stamina and safety in a matter of weeks. In the spring of 2026, the medical team abandoned the targeted pill and escalated to a heavier systemic assault. Luke was scheduled for cycles of intravenous chemotherapy paired with a new synthetic antibody called amivantamab. To stabilize his physical comfort, the oncology team integrated a specialized pain and symptom management clinic. This team used palliative medicine as a specialized toolkit for symptom control. By deploying medications like sustained-release morphine and pregabalin, they neutralized specific nerve signals and quieted the pain, which restored Luke's capacity to sleep and move. They also brought in specialized oncology physical therapists to help Luke understand his trapped lung. By learning strict physical pacing strategies, he could work with his newly limited oxygen supply instead of fighting against it. By June 2026, the recalibration was working. CT scans confirmed the pleural fluid accumulation was slowing and the structural disease had stabilized. The sharp, shooting chest pain was completely controlled. He was no longer running 50-kilometer races. Instead, Hugh was walking daily with trekking poles. actively pacing his exertion to maintain a steady, functional equilibrium. Surviving a metastatic diagnosis requires accepting that there is rarely a static endpoint. It is an ongoing, high-stakes process of monitoring structural failures, adjusting chemical arsenals, and continuously adapting to a rapidly evolving biological target.